With any type of surgery, there are risks and possible complications. For those affected by breast cancer going through breast reconstruction surgery, we're going to tackle a topic today that really is discussed quite a bit in the community that I serve at Deep Sea Foundation. So I reached out to an expert in the field. Dr. Emily Williams is at Plastic Surgery Northwest in Spokane in the beautiful state of Washington. I can say that. Although we are on opposite ends of the state, it is the beautiful Pacific Northwest. And Dr. Williams actually founded Plastic Surgery Northwest in 2010 after completing her surgical training at the prestigious University of Washington Plastic Surgery Residency. She works with a group of 5 other surgeons performing various aesthetic and plastic surgery procedures, including autologous breast reconstruction like DIEP flap. So I reached out to Dr. Williams to talk more about this potential side effect of fat grafting that's often concerning to patients, and it's fat necrosis. There are several studies that address this, and most recently, there is a study out of France, and there's another study that was done at the Cleveland Clinic. I'm going to put both of those in the show notes just so that our listeners can reference those and read them just to find out a little bit more information. But the important conclusion that I looked at from both studies is that preoperative, and I think Dr. Williams will agree with me on this in our conversation today, preoperative patient education and counseling is imperative to minimize fears. So I feel pretty fortunate that Dr. Williams has agreed to speak with us today so we can get a firsthand look at what surgeons do to mitigate the occurrence of fat necrosis during breast reconstruction, and that's whether it is for implant-based reconstruction or autologous tissue reconstruction. So welcome, Dr. Williams, and how is it on the other side of the mountains in Washington?
Well, it's a pleasure to be here, Terry. It feels very much like we're in Seattle actually at the moment. It's rainy and chilly out here, but it's great to take the opportunity for you and I to sit down and kind of talk through some of these important topics.
Yeah. How about, I'm curious, how did you get involved? Can you just tell us real briefly how you got involved in microsurgery? Because obviously you went to the great University of Washington here in Seattle, where I'm at.
Absolutely. What drew me to plastic surgery in the first place was really the diversity of the practice, as well as the collaborative nature. So the fact that we get the opportunity to sit down with patients and really delve into the details of what's motivating them and what's important to them. And microsurgery was something that I was extremely fortunate to have exposure to early on in my practice, like really early in the history of DIEP flaps. And so I felt very fortunate to have faculty around me that were doing that type of a procedure at volume at the time that I was going through the residency training program. I loved everything about DIEP flap specifically. The technical difficulty of it is something that is really appealing, and that has been the case as free flaps for breast reconstruction have become more diverse than the original DIEP flaps as well. It
Mhm.
gives us such options, I think, to provide patients with a really aesthetic and durable reconstruction in keeping with their own anatomy. Because, as you know, every woman is very unique.
Yeah.
Her goals are unique, her anatomy is unique. And so, being able to take a person's own resources and use them to the most benefit, I think, for her is something that was really a great opportunity. And microsurgery gives you more freedom to do that than any sort of rotation flap would. So it was the ability to achieve those goals for my patients was the thing that really drew me in the first place. And then, as I've developed more history with microsurgery, I love everything about it. So I am very, very lucky to have found myself in a position where this is something that I do a lot of.
Oh, okay. Listen, I just thought of something. I'm going to thank you out loud because I just realized you and I both showed up for the CMS hearing in June. And if I recall, that was an early morning for both. It was early morning for both of us.
Yes.
And I think you were probably prepping to go into surgery. So I just want to thank you from all the patient perspective, and the patients that I work with for showing up for us and for really driving a lot of the changes that we successfully made this year, because we all know that, gosh, a year ago, we were kind of fearful that coverage for DIEP flaps, the access to care was in danger. So I just thought of that, and I want to thank you out loud for that before we begin. So
Oh, well, thank you. And I feel very much the same about you and the efforts that you made. I think, one of us wouldn't have been able to do it, but I think when we combine forces, it's very powerful. And I think women facing breast cancer and their support teams have a very powerful voice. And I think that was really represented in the CMS hearing.
I do too. I do too. It was very moving for me. Okay, let's start out. I'm going to ask you the first question, which is how can patients recognize? I mean, the first thing is recognizing
Mhm.
fat necrosis.
Sure, absolutely. So, fat necrosis comes in many variations. And the first thing that I always tell my patients is that, that name sounds really scary. I think people hear the word necrosis, and it's something that makes you harken back to the days of gangrene and terrible infectious complications. And that truly is not the case when it comes to fat necrosis. What it is describing is basically a focus of fat cells that for whatever reason, and usually it's because of a lack of adequate vascular supply. Those cells have not survived being moved from one place to another. And that's something that can happen with both free flaps or fat grafting.
Hmm.
As well as other, options for flaps or tissue transfer. And typically, what women notice is a lump, something that they can feel underneath their skin, and that's something that could be as small as a BB, 1 or 2 millimeters in diameter, or it can be a large area. Although thankfully that's more rare. So, as you alluded to in prior podcasts, I think talking to patients preoperatively, educating them that this is something that is a possibility, letting them know what they may feel, because as you might imagine, women who have faced breast cancer and felt that lump, it can definitely be a triggering event to feel something again underneath their skin. And so that is typically the thing that they notice first.
Hmm.
Our patients almost universally reach out to us when they feel something like that as their first point of contact, and then we determine what needs to happen next.
Yeah. Now, so fat necrosis, correct me if I'm wrong, or
Mhm.
or explain this to us. It can it appear both in the breast and the abdominal incision for deep? So,
Yes, that is definitely true.
mhm.
It can appear both in the breast and in the abdominal incision. Most of the time, when we see it in the abdominal incision, it's near the central abdominal incision where the greatest degree of tension is underneath the
Mm,
surface of the skin and where the sutures are placed. And so sometimes people can feel nodules in that location also.
okay, good information. Now, varying degrees of this, I think, but does it always have to be removed? Does it have to be removed at phase two?
It does not have to be.
Okay.
There are many reasons why women would like to have it removed. So feeling that mass, I think, is something that's concerning to a lot of women, and they just don't want to have to have that concern, even if it's something that's been um, worked up and found to be a benign finding of fat necrosis. Sometimes it can cause discomfort or distortion of the reconstructed breast. And so those are reasons why sometimes part or all of the fat necrosis can be resected. But it does not pose a medical danger to a woman. And so it's something that doesn't have to be removed. I think that's a conversation between the patient and their surgeon as to how to approach it and what the pros and cons would be.
That's really, really excellent. I'm just going to share personal experience here because I still have fat necrosis, and guess where it's at? Over that radiated breast. And you
Mm-hmm.
mentioned earlier that blood source, sometimes lack of, and radiation affects that. And so I had that conversation with my surgeon, and because it is not painful at all to me, and because it was recommended to leave it there, because if it was taken out, it could leave an even more, um,
Mhm.
bigger divot or asymmetry. So we left it in. Doesn't bother me at all. So I really like the
Mhm.
way you explained that. Very, very good. Um, okay, so let's talk about specifically in terms of fat grafting, because that is a procedure where you use the cannulas. Are there ways that you can, put the fat in, so to speak, that minimizes the occurrence or the incidence of fat grafting? Or is it just, explain that to us? Is it just something that just kind
Yes,
of,
there certainly is, and I think that the key is to be conservative with the way that you perform the grafting. So, because what you're doing when you perform fat grafting is you're placing cells that don't, at the time that they're being grafted, have a blood supply. They need to be surrounded by cells that are healthy and have a good blood supply of their own. And so, what that means is each new layer of fat cells that you place, in the area that's being grafted needs to be completely surrounded by healthy vascularized tissue. And that's what really limits how much fat you can place into a grafted location. You can't put a large focus of fat, because then if you can imagine the cells on the inside of, say, like a marble size grafted area, they wouldn't have access to the blood supply from the cells around them. And then those cells on the inside of a large area of grafted fat would die and would be much more likely to form fat necrosis or an oil cyst, which is basically the same idea, but when those cells actually break down.
mhm.
So being conservative in your grafting, not placing too much fat into any one location. And as you're grafting, making sure that you're doing thin layers of grafted tissue amidst those normal tissues, I think is the most important thing, not getting overzealous. And as you mentioned, with radiated tissues, that's something that's even more important, and I think more challenging, because radiated tissues tend to be thinned out. They tend to be more affected by cicatricial changes or scarring in the tissues that make it difficult to place those fat cells. And so you just have to be really patient and cautious in the way that you're doing your grafting to ensure that those cells that you're moving have the best access to healthy cells with blood supply that you can.
So in a way, you're kind of building a nutrient-rich scaffold, just thin
Hmm.
layers that, yeah, that,
That's exactly
okay.
right. Hmm.
Yeah, okay. All right, let's say that a patient gets to phase two, they have some necrotic tissue, some fat necrosis that needs to be removed surgically. How then, can you explain a little bit how you go about doing that, and then maybe filling in those anomalies, or how you take care of that then?
Sure, absolutely. So, typically when we're talking about surgically resecting areas of fat necrosis, what we're talking about is not just a tiny little, BB-sized nodule, but something that's a larger focus within deep flap, for
Mhm.
example. Unfortunately, most of the time where that area tends to occur is the upper inner aspect of the breast, because with a lot of deep flaps, that's the area that's the farthest away from the actual blood supply, the perforating blood vessels that are coming into the tissue.
Uh,
Um, and that tends to be an area that's very aesthetically important, the upper inner aspect of the cleavage area. So that's part of what makes that decision really challenging. Essentially, what we do if we decide that that area of fat necrosis needs to be removed is we typically, use incisions that have been determined preoperatively with the patient, elevate the skin flaps from the mastectomy, and then find the focus of fat necrosis. And with experience, you can really see the difference between the fat necrosis and the normal cells that are adjacent to it. And so, just like you would remove any sort of abnormal tissue, you can resect that fat necrosis. And it does, unfortunately, oftentimes leave a defect in the area that you remove that fat. And so that is tricky to fix a lot of the time with fat grafting
Mm.
because of the things that we just spoke about. You're removing that area of fat necrosis, and what's surrounding it are thinner layers of subcutaneous tissues. And you can't just refill that spot with an equivalently large area of grafted fat, because that area of grafted fat wouldn't have access to the blood supply that it needs.
Mm.
So a lot of the time, what we'll do is actually elevate a portion of the flap, move it into the area where the area of fat necrosis was removed, use stitches to hold it in that new location, and do fat grafting throughout that area in order to restore the most normal and aesthetic contour to the breast that we can. But it certainly can be tricky.
Would that be considered a little bit of oncoplastic surgery involved in that as well? Or
It's, I think oncoplastic surgery really refers to almost everything that we're doing
I
throughout this whole process, if you think about it. So I suppose the answer to that question would be yes. Basically what we're doing, regardless of under what circumstances we do it, whether it's parenchymal rearrangement after a lumpectomy or something like this, we're adjusting the healthy tissues around an area in order to restore an aesthetic breast contour.
which is what oncoplastic surgery is. You're right. So if this necrotic tissue has to be removed and more fat grafting take place, movement of tissue, is the recovery any different than it would be for just, I know there's not a quote unquote normal phase
Mhm.
two. It varies, but I guess maybe my question is, what does the recovery look like for patients?
Mhm.
You know?
I would say that it's not significantly different, although one thing that can be significant to patients is if it's a fairly large area of fat necrosis that needs to be removed and there's more work that's required underneath the surface of the skin, it's more likely that we would need to place a drain to allow the
Mm.
tissues to readhere to each other. And I can tell you that is something that every single one of my patients ask me before phase two is, am I going to have those drains again? Because it's something that nobody likes to have. So that's something that can be a difference. Even if we do have to place drains, though, they're really quite short-lived. It's unusual to require them for very long. And then I would say the majority of the recovery is very similar, regardless of what approach is taken to that phase two surgery.
That is super information. I'm glad you brought this up because I forgot about the fact that I do hear women say, I had drains after phase two and I didn't know I was going to. So you explained
Mhm.
very well why we have to, and that yes, they are far more short-lived than phase one. So, and they
Yes, thankfully.
drains probably the least favorite part of this whole recovery process, I would say, just
Indeed.
because they're a little bit cumbersome. And so,
Yep.
um, so what about physical therapy? I know it's not recommended after phase two because that fat has to, adhere when you do fat injections. But what about after phase one, after your initial breast reconstruction in the setting of deep flap? Do you ever recommend physical therapy? How do you feel? Because I hear varying, reports on that as well.
Yes, I try to get most of my patients into physical therapy by 4 to 6 weeks or so after their surgery. I think it's really helpful in a lot of ways. And I think it's something that can be helpful with softening areas of fat necrosis. It's a similar approach to what's taken to scar tissue throughout the operated areas,
Mhm.
massaging those areas, allowing that collagen to realign, softening those scars. And I think that that's something that can be really helpful for fat necrosis as well. We are also very fortunate to have a number of really good massage therapists who do great lymphatic massage and can really help with management of fluids and softening of tissues as well, that work around our group. And so I think those can all be really helpful things for patients.
Yeah, good. Now, let's say that a patient, she expresses that fear. Gosh, I found a little lump. I don't know what
Mhm.
it is. When then do we, not we, but when do you and your colleagues and other surgeons decide that it's time to order more imaging, and what type do you generally recommend for patients?
Sure. So typically, nodules are something that aren't noticed by patients in the early postoperative period, typically because of the swelling, and it's normal to have some lumps and bumps. And so I would say that it's something that usually solidifies into something that is consistent and could be a concern around 3 months or so after surgery. And at that point in time, things have settled enough that it would be appropriate to do imaging. We're fortunate to have a close relationship with our breast imaging radiologists. And so, oftentimes we'll reach out to them and just say, what do you think is going to be the best initial modality to image this area? But a lot of the time, the initial study is an ultrasound.
Mhm.
And then that's something that can both be diagnostic, and if it's felt that a biopsy is warranted, it's something that can facilitate that as well.
Yeah. Okay, that's good. I think that coordinated care is so important
Mhm.
between, yeah, so okay. So you kind of answered my next question then. Once a patient has reconstructive surgery, it's best to call their plastic surgeon first, I would think, rather
Yeah.
rather than like your breast surgeon or primary
Mhm.
care.
Mhm. I think so, especially as you're going through that, through the reconstructive process.
Mhm.
I think that as we're engaging in those reconstructive surgeries and a person's going through that healing process and these questions are coming up, absolutely reach out to your plastic surgeon, I would say, is your first point of contact. That's something that could potentially be a little bit different if a person was a long ways out from their initial surgery. Say somebody's 5 years out from their reconstruction and they feel a new mass. That's something that absolutely they can reach out to their plastic surgeon, but I think it would also be reasonable to reach out to their oncologist or their surgical oncologist, really whoever they feel most comfortable contacting at that point in time. You can't go wrong because I think anybody is going to pursue a workup of something delayed like that. But plastic surgeon definitely would be the first person to go to during that reconstructive process.
That's a very good advice within that small window after the reconstruction. Okay, well, what did I leave out? Do you want to add anything else to this today that I didn't ask?
Not that I can think of. Um, I think patients do an excellent job of informing themselves of what to expect and what questions to ask. And this is, I think, a common question that my patients ask me about. I think it's also one of the advantages of the really thorough informed consent process that we all go through at this point in time. Fat necrosis is something that they read about, they hear about, we talk about. It's something that is not common, but also not uncommon. So I think it's important for women to hear about it. It happens in right around 10 to 15% of grafted fat or DIP flaps. And so it's something that a lot of women are going to experience. And I think the biggest thing is just ensuring good communication, whether it's before or after surgery, and reaching out to your surgeon and their team to make sure that if there's something that's concerning you or you just have questions about, that you're getting those questions answered, because it's certainly something that we've seen a number of times. We know how to manage, and we're happy to make that as smooth of a process as we can.
Well, listen, Dr. Williams, you succeeded in um, really, reaching my goals today, which I just like patients to be able to sit and listen to other surgeons who are so well qualified like you, because it does, the main reason was to dispel fears about fat necrosis. And if they can have this conversation after listening to all of the, great points that you gave us today, I think it will really help in the process. So I appreciate your time. And again, I'm talking to Dr. Emily Williams in Spokane, Washington at Plastic Surgery Northwest. Thanks for joining us today.
Absolutely. It's been my pleasure, Terry. And thank you so much for everything that you do.
Oh, of course, it's my pleasure. Thanks.